Hi, my name's Conor Delaney. I would like to welcome everybody to another edition of MD Insight, and I'm delighted to be here today with Dr. Sarah Vogler. Dr. Vogler recently joined us as Chief of our section of Pelvic Floor in the Department of Colorectal Surgery in the Digestive Disease and Surgery Institute at Cleveland Clinic. Sarah's got a lot of clinical experience, but also has a great business understanding and has an MBA as well as her MD. So I think we should have a really interesting and hopefully fun discussion. So Sarah, welcome. Thank you for being with us. And maybe a kick off just introducing viewers to you and why you do what you do and what makes it fun.
Yes, thanks for having me. So I came to the Cleveland Clinic, it's almost been a year ago now, and joined the Department of Colorectal Surgery, which has been a great department, lots of energy. I have the opportunity to start building more of a pelvic floor section here, which has also been fun, a little challenging recently with the pandemic, but a lot of opportunity, phenomenal people to work with in urology, urogynecology, gastroenterology. So a lot of people to meet, but a lot of opportunity and a lot of innovation going on.
Yeah, it's been a great group, and I hope that's one of the cultural things here, that we've been lucky to have such multidisciplinary groups. But you alluded to the pandemic, and obviously coronavirus or COVID-19 has changed everything. And maybe talk a little bit about the short-term changes in practice, because we can dive into it and talk a little bit more about it philosophically and financially. But just for day-to-day practice, how has it changed for you, and how have you managed to deal with it and yet continue to provide care to patients?
Right. It's been a challenge for physicians and for patients, for the whole healthcare community, because healthcare has probably always been a little bit behind. I mean, I can have my dry cleaning picked up at my front door and not even be home. And healthcare has always kept this very personalized touch to it, where you go and you see your physician and their nurse, and nothing's been done as much virtually or hands off. So the pandemic's forced us to kind of take a crash course into this patient engaging technology, virtual visits, a lot more done by phone and remotely. And I think we've done a good job with it. There's been stumbling blocks every day. Somebody will come up with a new challenge. For example, as a colorectal surgeon, asking how in the world you're going to examine hemorrhoids virtually. But it's going to be good in the long term. I think having this virtual platform that we're developing is improving access for patients, and it's improving overall convenience for providers and for patients. It's allowing us to streamline the way we think about patients. We're not having as much kind of just overall patient traveling through the hospital, traveling through the clinics, providers going back and forth. I think we've kind of improved our efficiency, if nothing else, in the last couple months.
Yeah, it certainly changed everything, that's for sure. And I think for pelvic floor and colorectal, it's a little different for us, because we've traditionally needed a physical exam, at least for part of the examination. I remember a few weeks ago, somebody sent me something online about a new iPhone app for a rectal exam. And then I realized it was April 1st, and that doesn't exist yet, but you never know, a business opportunity. So
right, I'll retire if that becomes a real thing.
There you go. There you go. So, but I think for providers day to day, some of us have done virtual visits for years, and obviously it's become a bigger part of our practices now, but many haven't. So maybe you talk a little bit about the different types of visits, because it's changed it. And at the end of the day, people often need to code and be reimbursed. Not often, do. That's our style of practice, at least in the US. So maybe you talk about the business and coding side of it and the different visit types that there are.
Yeah, I think some of the slowness to virtual visits expanding in medicine has been the difficulty in getting coding and reimbursement to catch up. So the pandemic, just to keep everybody safe, providers and patients, forced CMS and some of the payers to recognize that virtual visits really do need to be an option. You can't provide care without adequate documentation or some sort of reimbursement for your time. So having the pandemic push CMS and payers to provide new coding methods and reimbursement methods for these virtual visits has been absolutely critical, and it's pushed this technology to move on. So the way we set up clinics at this point is still fairly similar. I could have patients being seen every 15 or 30 minutes but now I'll bounce between in-person versus virtual. And then my documentation and my coding is pretty much following the same pattern, although payers, including CMS, are recognizing that slightly differently. Some of the challenge is not only for the provider to be very savvy with different technological platforms, but also your patients to be savvy about it. And what I've learned is that almost all my patients, they mostly tend to be over 60 years old or so, but they all have grandchildren. And all of the grandchildren are very savvy. They just have no desire to hear about grandmother's, bowel problems. So they tend to help with those platforms on the patient side. But it's been comical in some senses to be able to talk to a patient and say, do you have a neighbor or somebody else who can help you with this iPhone or iPad app? And work it into their day. I think it's actually helped a lot of my patients to be able to include some of their caregivers in their care. Whereas when you have a visit with somebody in the clinic, their children may not be able to attend that visit, or whoever does have to care for them may have to be at work at a different place. So being able to have those people log into a visit and see it has actually improved streamlining, okay, when do you want to have the surgery? What should we do next? And I think that's one thing that'll make it stick and it'll stay. How to actually code and then bill for these visits is becoming easier. There's a few little hiccups as to what platform you use. Most of my older patients would like to just talk to me on the phone, and that's nice, but we're a little unsure as to if that's going to stay around. I personally like to see them on video because I can tell if they're understanding what I'm saying. I can see when they're bickering amongst their spouse as to what they're saying is wrong. You can kind of tell their facial expressions if they don't understand. And so I think virtual visits from a video platform is going to be reimbursed equivalent to in-person. We just have to be able to make sure we get the technology there and our patients on board with hitting those technology goals. What are you seeing? Do you have the same problems with your patients?
Yeah, it's interesting. So I think firstly, it was a fantastic transition by CMS just to open it up, because it's definitely the future. I guess it's the present in a way, but when we think of the future of care and efficiency, absolutely, we've got to be providing virtual care where we can. I think what we're seeing in practice is it's allowing us to be more efficient in a few ways. First, for the patient, they don't have to spend several hours traveling here, or even if they live locally, they don't have to commute and park and walk. I think it's really nice. I did a really interesting virtual visit last week with somebody out of state who was in a nursing home with a complex abdominal situation. And you mentioned caregivers. The PA at the care facility was holding her phone and was doing the virtual visit. And her family, her 4 family, were dialed into the visit on her iPad by Zoom. So the 4 family were there, the patient was there, the caregiver was there, and it worked. And you're right, I think the video side of it's really critically important. You see how patients are, if they're post-op, you see if they're well, if they're not well. We get similar visual clues to what we would in clinic, but it's certainly different. Going forward, I think it's going to be hard for payers to dial it back. I think there's going to be great patient demand, great efficiency demands, and where exactly reimbursement lies, we're going to find out in time. Hopefully it's similar, because otherwise it may crush a number of providers, and it'll likely be similar for that reason. But I agree, telephone visits are probably a little different. What about the documentation side? How, I know you know a lot about this, and so just pull a little bit more information out of you for people who might want clarity about how they should document these visits, and what the level of documentation is, and how do you document the different components of a physical exam, because it's meant to be a similar level of documentation. Maybe you clarify that a little bit.
So similar to in-person visits, there's 2 ways to code these. One is purely based on time. So if you spend 30 minutes with a patient, depending on new or established, that will get you a certain level. The other way to code it is based on medical decision-making and physical exam. And that's really probably your most efficient way. So all this documentation and time you spend understanding their medical problems, their medications, asking them this breadth of questions that encompass all the different systems, you're going to drive your better coding and billing methods towards a higher level visit, say a level 4 or 5, in less time if you can document it well. They've actually made very few requirements as to how to document differently for a virtual exam. You have to document certain times that you've had consent provided to continue in a virtual platform to have the exam, and you have to perhaps document time spent more specifically if you're going to document that way. But if you're documenting based on your medical decision making, it's going to completely mirror how you would document that in person. There just are the same challenges to physical exam. So getting your 8 or 9 points in a physical exam is possible. It's amazing how much we pick up on visual cues that we never probably thought about when we were in person. But when I'm talking to a patient, and they'll frequently have to stand up, sit down, walk around, or I'll ask them to do that stuff, you're seeing coordination, you're seeing how well they can interact with you, follow commands. Just some of your questioning tends to give you a good insight into, did they remember this? Do they understand that? How, can they bend down? Can they sit up? Is this causing them pain? I ask patients, can you point to where it hurts? Can you push there? Can you show me incisions? There's a lot of stuff you can do that is just visual, and I don't think we ever thought of it that way when we were in person. We thought we were physically doing something, but in reality, we were probably just sitting there observing a lot of that stuff. So we have made a virtual visit template that has a physical exam for us to use here, which has helped guide some of that as far as, do they look like they're comfortably breathing? Can they carry on a conversation coherently? Do they remember past remote, recent events? So it'll allow our staff to get to the level 4, level 5 visits and still hit the number of systems they need to. And then really medical decision making is about the same, if not easier to hit a higher level, because during that virtual visit, you're making decisions as far as when they come to see me, I want them to have a CT scan, labs, pre-op, urology consult, and then my consultation. So when you hit 3, 4, 5 things a patient needs to do the next time they see you in person, you really are driving your medical decision making up instantly at that point to hit a level 4 or 5 visit.
Yeah, absolutely. And I must say, for me, my note ends up looking very like a clinic note. In fact, exactly the same, except the first line says I met somebody through a virtual visit or not. And I think that's critical, as always, is appropriate documentation and documenting the complexity and and the decision making and the tests you need. But what it also gives us is the opportunity to be more efficient for patients. We can see them, and like always, they never have all of the tests done or sent to us when they get here, or it never seems to happen for me, not very often. But you can always then have highly targeted tests, so they know the right test to have done, or when they come here in person, we can do a very specific imaging test or other things. So one of the other things about virtual visits, obviously, is it allows providers to be more flexible. And burnout's been a real issue for providers. And some areas of the clinic, providers have been able to see patients in the evening. Nice for patients, but also meaning they can get a morning off, or Saturdays versus weekdays. What are your thoughts about flexible hours going forward, and how we should implement them, and really what are the consequent benefits potentially for patients and providers?
Mm-hmm. I think it'll be a little bit of a challenge. So physicians are creatures of habit, which probably makes us really good at what we do because we like to see patterns and do things the same way. But the pandemic has highlighted how that's going to change. So our patients who might have been at home, not able to work or working from home for the last few months are now jumping back into it. And they're just not going to be able to take a half a day off to come to the clinic and see us and do 3 tests. So the convenience factor for them to be able to see their physicians in the evening or on the weekends is going to be imperative to us maintaining and picking our volume back up. That being said, I think the virtual platform will allow at least physicians to have some more flexibility in what they want to do too. So there are probably opportunities that we just not noticed. If I were to have an evening clinic and not come in until 9 or 10 in the morning rather than getting here at 6:30, I think that we would adapt to some of that. It probably doesn't sound real attractive out of the gates, but I think when you get to see patients and I'm helping them in a way that I wouldn't have been able to help them at 9 a.m. when I just would have been talking to them and their whole family wasn't there to take part in this conversation. I think you get that rewarding part of it from the patient, and then you kind of adapt your own schedule too to find out, this is worth my time to do it in off hours. I do think it'll have to be more of an adjustment than an add-on because it is a change to everybody. So I think probably working more is less appealing than just working at different times. So that's something that we'll get better at. And I think hopefully physicians will kind of drive their own path as to how their patients are asking for evenings, weekends, and what they enjoy doing and find to be more engaging than perhaps being at work and having those slots not fill or not being as busy as you used to be.
Yeah, I agree. I think it'll change. We'll learn it. We'll get used to the difference. We'll try and really realize some of the opportunity. But I think especially now with all of the social and economic consequences of the pandemic, we really have to think of this as the patient will see you now, as opposed to the way we've often provided care, which is, this is when we're in clinic, you have to try and get here during those hours. So swinging back to kind of your clinical specialty, so how are you seeing this play out in how you time investigations, testing, patients showing up for pelvic floor? Just as we close, what are your thoughts around how it'll, directly affect a pelvic floor practice?
Yeah, pelvic floor is unique because it causes these vague symptoms, so constipation, incontinence, pressure, that I don't have magical powers to understand when I see a patient in clinic anyway. So it's somewhat driven on what kind of testing you can do to physiologically grasp strength and what's happening. And I think being able to talk to patients virtually and understand what are their real complaints has allowed me to kind of hone in on, this is the test I need for you, and this is the other partner in crime I need to help treat you. So instead of just coming and seeing me and then coming back 2 or 3 times, it's allowing me to coordinate combined clinics with urogynecology. So when they do come, they're seeing myself and a urogynecologist in the same clinic visit, and we can time it so they get testing before they see us, which I think patients really enjoy, because rather than seeing me and then going and getting testing and I wonder what that test actually showed, we're going through all those testing results right then and there, and they're hearing the next step in the plan rather than going home and wondering what it's going to be in a couple weeks. So it's been great, I think, from a pelvic floor standpoint. It's also a population of patients that they're hesitant to go see the doctor for some of the complaints that they have. So when you can streamline their care, they're more likely to follow through with the treatment plan, I think. It's hard to take time out of your day for something that you know is not life-threatening. So when they do take time out to treat it, it's important to be able to provide them with as many answers as you can in one sitting.
Yeah, I agree. I think it's going to allow us redefine how we provide patient-centered care. We'll be seeing them in their living rooms. And then they'll come here for very targeted investigations or treatment, and it'll be more efficient for them and better quality for them. Certainly it's revolutionized how we see post-ops and other things. Well, Sarah, look, I just want to thank you so much. It was such a pleasure to chat and learn from you about all the different things you're doing and get your perspective on the future of virtual and other care. I really appreciate it.
Yes, thanks.
Well, everybody, thank you for joining us, and I look forward to seeing you all on another episode of MD Insight in the near future.